What advice would you give a high school junior looking to make a career as a military physician? Well, I would break it down into 3 areas: military service, academic performance, and medicine in 2021. First, be brilliant in the basics. Make sure that you don't do anything that disqualifies you. That means being physically fit. Work out, eat well. That means staying out of trouble with the law. That means making sure that you are ready and willing to serve when it's your time. A lot of that has to do with how your outlook is, because we need a diverse set of future leaders. We want you. The more leadership experience you can get, even if it is being in charge of something as basic as a school club or a volunteer group, will benefit you tremendously. Next, academics. The hard part of becoming a physician is getting through college and getting into medical school. You're going to need to study hard, but you should enjoy all college has to offer. Choose a major that aligns with medicine, but pick something you like just in case. Medical school appreciate applicants who have an outside interest and a wide array of experience which inform their interest in medicine. Finally, getting into medicine itself. Is it really what you want? It's not what you see on TV. So volunteer at a hospital or a clinic. Get your EMT. Ask the hard questions and make sure you want medicine. Quite frankly, if you think you might like something else, do that. If the only thing you can imagine being is a doctor, and you want to serve in uniform, you want to serve with the best people and have the best mission, well, welcome to Navy medicine. When will we know for sure if our specialty will gain or lose billets? There are 3 things that play here, and I want to walk through each one individually. First, DHA transition. Second, medmaker. And finally, divestiture of billets. So first, DHA transition. Currently, DHA is on Plan 3 and working their way towards taking over and setting up their markets. This will realize and have some of Navy medicine administrative folks transition to DHA. However, by and large, it will not affect our specialty makeup. 2, medmaker. Whether you realize it or not, we're constantly evolving. We are a learning organization. We are working towards the Surgeon General's 4P, we're working towards the CNO's plan, and we're working towards the Commandant's Force design. So we will continue to evolve that so that we can put the best people at the best places at just the right time. And finally, divestiture. The Navy is under tremendous pressure to be able to make the most lethal force knowing in the world on the sea. In order to do that, they have to make really hard decisions. And one of those hard decisions that was made was to divest of some medical so that they could invest in other areas of the Navy. Now, what does that look like? We're not sure at this point. Congress has asked for a better defined explanation, and the Navy is going to provide that. So as we move forward, I will continue to update you so that you know exactly where we're going. So as you see, it's not just one thing that's causing a difference in our billet structure. There's actually 3 things at play, and they become confusing. That said, don't be alarmed. You're all important. We need all of you to meet mission. In order to maintain clinical skills, some of us moonlight at hospitals where higher acuity and volume of patients are available, but are required to take personal leave in order to work. Could there be a policy in place to allow for no-cost TAD and not dock personal leave meant for rest and relaxation? The simple answer is no. You're on active duty and you're being paid by the government to be able to provide a service. Yes, some of you use moonlighting to increase those skills, but that should not be necessary. It is incumbent upon us, Navy Medicine, in order to provide you an opportunity in the place you are stationed to have the diversity, the acuity, and the volume of patients in order to maintain your skills. Sometimes we're not able to do that, so we will TAD you to a place for you to work in perhaps a civilian hospital, but you cannot be paid to do that. Otherwise you would be getting 2 sets of pay, which is illegal. We are working hard to make sure that our specialty mix is correct at the locations that we have to provide you the volume and diversity of patients that you need to maintain your skills. But thank you for the question. How are critical wartime specialties defined? Is there consideration of review and additional specialties being added to the list? Critical wartime specialties is a phrase that gets used a lot, but unfortunately it's often misunderstood. There is no standard list of critical wartime specialties. For example, psychiatry is included on some and not on others. The word critical is often used to mean that other specialties are non-critical. That's just not true. Often the critical portion simply means that our manning is critically low or is projected to be low in the future. In most conflicts, disease and non-battle injuries create the most casualties and are not just treated with trauma surgeons and anesthesiologists. Even with some of the reshaping that's going on right now, all specialties have a place in Navy medicine. Pediatricians are important to the operational platforms and requirements. OBs are important to the operational platforms and requirements. Our operational medical initiative is encouraging all physicians to not only have a clinical specialty, but an operational specialty as well. Your clinical specialty can be radiology, but your operational specialty might be flight surgery. Or you can be an FMF qualified dermatologist. I encourage people to focus less on the term critical wartime specialties and realize that all specialties have a place in Navy medicine. What is the direction for further straight-through training versus general medical officers? We have started a 6-year plan to move from our current interrupted system of training to one that will train most medical students going straight through. This transition will start in academic year 2022 and progress over the next 5 academic years. This long transition period will give each specialty the time to make the changes they need while doing everything we can to train all the qualified GMOs that are currently supporting the fleet. We will never probably get out of the GMO business. The Air Force and the Army have gone through this for the last 10 to 20 years and they still have GMOs. So there will be a place for you if you desire to do a general medical officer tour. However, in order to be competitive, in order to offer the best and the brightest an opportunity to serve in the Navy, we need to be able to have a pathway for straight-through training. Finally, what changes are we expecting with NDAA 22 and billet divestiture? Folks, with the change in presidential administrations, there will probably be a fresh look at all the changes being proposed for military medicine. That said, I would never try to predict what Congress may or may not do. I can tell you that the Commandant and the CNO are all in to support Navy medicine. The Surgeon General and our senior leaders will do our very best to inform decisions. I can 100% relay that you are important to Navy medicine, and I'm always available to you. I'll see you around Navy medicine. Doctors, we walk in the footsteps of giants. The last 150 years of amazing accomplishments provide the base for the heights you will take Navy medicine in the future. So happy 150th birthday, and thank you for all that you're doing around the Fleet and Fleet Marine Corps.